All right. So usually in talks, you like to keep the audience in suspense till the end is to get the result. But I think that I'd like to just tell you a little bit about this before I start the formal lecture. So in 2010, I had a patient come in that was exposed to a loud blast that blew out his eardrum on one side, and he developed hyperacusis. And I had never seen a patient with hyperacusis before. And he said that sound was bothering him and that he couldn't go in a noisy place, and he wanted something done about it. So I said, well, maybe we should try to put some tissue in your ear to block the sound waves from going into your ear, and maybe you'll feel better. And he said, Doc, do whatever you can to see if it works. Well, we took some tissue from above his ear and put it inside his beneath his eardrum, and fortunately, he had a great result. And then it was 4 years till I saw the next patient who came in with hyperacusis in both ears. And in that patient, we said we had done this once before, and we found that putting some tissue in there may help. So we did it on her, and we did both ears, and she turned out to be a star patient. So we decided to do a research project to see what would be the best amount of tissue to put in the ear to get the best symptoms relief. And so we started out with putting in very little tissue on the round window membrane, which is one of the windows in the ear for hearing. And that seemed to work out pretty well. And we found out after doing that for several years, we had a patient that we noticed the stapes bone, the third bone of hearing, was very loose. And we said, well, why don't we put some tissue around that? And that patient got an even better result. And then, so then we added stapes reinforcement to the round window reinforcement. And that went on for several years. And then recently, we did a paper where we divided our patients up into two categories, one that were severe and one that were moderately affected, and found that putting more tissue in the patients that were severely affected got a better result. So that's the story that I'm going to tell you today. I've been in the building now almost 22 years. I have no financial relationships to disclose. And let me tell you a little bit about sound hypersensitivity. There are 4 types: the hyperacusis, recruitment, misophonia, and phonophobia. Hyperacusis we'll talk about shortly. And it's a condition where a person cannot tolerate normal sounds. They become anxious and avoid places like movies, restaurants, and sporting events. It often affects their quality of life, and supposedly 6 to 17% of the population are affected. They could have normal hearing or a sensory neural hearing loss, and their uncomfortable loudness level, or LDL, is below 90 dB. The normal is between 90 and 100 that most normal people can tolerate. Many of the patients have tinnitus in their ear, where they have ringing associated with it. And a lot of the patients have pain also when noise is placed in their ear. And patients try to treat themselves with earplugs, and there's tinnitus retraining therapy, TRT, cognitive therapy, and long-term treatment is needed, but many times the results are variable and are not effective. So the second type of sound hypersensitivity is recruitment. This is a sudden marked increase in sound occurs when the patient reaches a certain threshold of their hearing. These patients usually have hearing loss and they have Meniere's disease. And when the sound gets loud enough, they suddenly get a tremendous blast of sound in their ear. And the treatment is the same as for hyperacusis. Misophonia is a reaction or an irritation to certain sounds, like water dripping, chewing, pencil tapping, or chalk on the board. Phonophobia is a fear of sound. These patients are afraid of sound. Their LDLs are normal, but they need psychotherapy to help them. So the cause for hyperacusis is unknown, but many of these patients have had noise trauma, which is very interesting because we're taught that noise causes hearing loss and not hypersensitivity of the ears, but it definitely does cause hyperacusis in many patients. Trauma to the cochlea, like a slap injury to the ear or a head injury, superior semicircular canal dehiscence, which is a little defect in the bone of your semicircular canal, perilymph fistula, adverse reaction to certain medications. And several years ago, we found that there was hypermobility of the stapes in many of these patients, which means that the little third bone of hearing vibrated very a lot to palpation. So the possible mechanism is impaired neuroplasticity in noise suppression, hypersensitivity of the cochlea to sound, and hypermobility of the stapes. The hypothesis is that possible hypermobility of the stapes or hypersensitivity of the cochlea to sound can be reduced by placing tissue against the round and oval windows to reduce the sound vibration and reduce the symptoms. So the literature research showed when we first started doing this, there was only one patient that had hyperacusis surgery, and that was a patient that had superior semicircular canal dehiscence, and they had relief when they had tissue placed in the round and oval window. But there was no other reports. We talked about the first patient, so I don't have to. Here's the fascia that we put in the ear in the patient over the oval window and the round window in the first patient. The second patient I talked about that I saw 4 years later, again, had tissue placed in their ear. And the way we do that is we take some tissue from above the muscle, above the ear, and make little round pieces of fascia. We make actually 10 little pieces of 2 millimeter pieces and several pieces of 4 millimeter fascia. So I want to show you this little video. Hopefully this will work. Of course, this is supposed to work when I click it. Okay. So we're palpating the stipe. As you can see, it's very loose. It shouldn't be moving around like this when you touch it. So this was one of the first cases of hypermobility of the stapes. And you'll see us putting the tissue in. So now we're using electrical stimulation of the facial nerve and the chordotympany nerve, and you can see the incus moving and the stapes moving. So we'll reduce the mobility of the ossicles by putting the tissue in. Now you can see we have placed tissue all around the stapes, and the stapes does not move as much. And then we also electrically stimulate the chordotympany nerve, and again shows reduced contractions of the stapes. So you see hardly any movement there. And this patient had a wonderful result. So the bottom line of all this, it appears that the more tissue that we put in on these patients, the better result we get. And in the last patients, as you'll see near the end of this talk, have gotten the best results so far. So the purpose of this study was to evaluate the effect of this surgery in reducing the symptoms of hyperacusis. And we did a hearing test, the LDL, which is the loudness discomfort level on all the patients before and after surgery, and a CT of their temporal bones to make sure they don't have that fistula that I was talking about. They do a hyperacusis questionnaire, and they measured their severity from 1 to 10, 10 being the most severe. And there's also the GBI inventory that they take that evaluates the result of the surgery. The GBI evaluates the general health status, the physical health status, psychosocial health status, and social support. And we see the patients at 1 week, at 4 weeks, and at 1 year. So here you can see another picture showing the round window being reinforced with the 4-millimeter piece of fascia. We placed 2 pieces of 2-millimeter fascia beneath this. And then this is the oval window being reinforced. Several pieces of fascia are being placed here. Here's some more fascia being placed around the window. So we divided the patients up into 2 loudness groups. 52 patients were in the moderate discomfort group. So in other words, their LDLs were between 70 and 90. And then the second group was 21 that where their LDLs were below 70 dB. And those patients had high discomfort to sound. And these were the very serious patients and very difficult to treat patients. So in the moderate group, 80%, 81% would recommend the surgery, and 72% stated that the improvement lasted over a long period of time. The follow-up was from 1 to 6 years. In the LDL group below 70, which were the very high discomfort group, only 47% would recommend the surgery. So it was about a 50-50 deal if the patient was very severely affected. So we wanted to improve these results. And by doing that, we developed the enhanced reinforcement of the round and oval window. And what we did was put another piece of fascia, 4-millimeter fascia, over the round window and oval window reinforcement that I showed you before. And then we put another piece of fascia underneath the eardrum to reinforce the eardrum. And the results have been very good. So the LDL in this patient was 65 dB before the surgery, and a week later it was 95. And this patient was ecstatic about the result. So 4 of the 5 patients have had very good results. And we're doing the 6th patient on this Friday. And 3 of the patients stated that the surgery prevented them from committing suicide, which I think is an amazing thing. Now, the other thing that happens is that the unoperated ear may improve by the surgery or the 1 ear. And the second ear may not need surgery if it is not bad. The unfortunate thing is that this did not help any patients with their tinnitus, and that had to be treated in other ways. So in conclusion, the LDL is a good predictor of the possible success of round window and oval window reinforcement surgery. Those with a pre-op LDL 70 dB or greater have an 81% chance of improvement, while those with a pre-op LDL 70 dB or less have 47% chance of improvement. And the patients will do better with more tissue reinforcement, adding to the graft. graft to the tympanic membrane and reinforcing the round and oval window reinforcement. Thank you. I'll take some questions.
Yes, so now it's okay to ask?
Pardon me?
Okay, what I want to ask is, so now is a 50-50 chance if you are, the LDL is below, if the LDL below 70, so it's 50-50 chance the surgery will help?
Right. But that was before we started putting the extra tissue in. I think it's much higher now because four out of 5 patients were very good results. So I think the results are going to improve quite a bit on those patients. And even the group that has 80 dB, 80%, we're putting more tissue in that group too, because we wanted to improve the results in that. The bottom line is the more tissue that put in, the better the result.
Okay, another question, and that's it. Oh, speak louder?
Yes.
Okay, so another question is, if you, okay, it doesn't matter, I will ask later, maybe someone else.
Yeah, I would like to know, are people put to sleep or are you awake when the surgery is done?
I can't hear it.
Are people put to sleep or they awake during the surgery?
Oh, all the people go to sleep just for comfort. We've done many surgeries under local anesthesia in the ear like this. It could be done under local anesthesia, but I think it's just more comfortable for the patient to be asleep.
Questions in the chat.
Yeah.
Is this surgery available by other doctors? And one was asking for New Jersey area. If this procedure can be done.
This we've trained a number of fellows here how to do the surgery, and I'm not sure that we have somebody in New Jersey that's can do it, but
Question is, does adding more tissue affect hearing at all?
yes, that's an excellent question. So there appears to be a little bit of hearing loss from adding the extra tissue that's temporary. And after a few weeks or a month, the hearing comes back to where it was before. We've had a couple of patients that have had a high tone hearing loss, but all these patients, interesting, have never complained about the hearing loss. In fact, they're happy to have a little bit of hearing loss because it gives them less hyperacusis.
Next question is, does this help patients with cochlear implants?
I don't think so.
What would be the
I would
result?
like to ask a question if I can.
Severe pain, hyperacusis.
Great question. For some unknown reason, almost every patient that we've operated on with pain from the hyperacusis has had their pain gone. The hyperacusis may not be perfectly cured, but the pain seems to respond to the surgery very well.
So the next question is, how are we supposed to travel if the travel causes pain?
Say that again.
How are we supposed to travel if traveling causes severe pain?
You can try to wear the earplugs. I don't know. It's a problem. We have doctors in Las Vegas that can do it. The surgery doctor in in California can do it. And I'm sure more and more doctors will be doing this as it becomes more and more popular, because it's not brain surgery and it's not difficult surgery to do. And it's not difficult to learn how to do this surgery.
Like John Wallace has a question.
I'm not sure. That may have been my name that I heard.
Yeah, John Wallace.
Yes, that's me, if you can hear me.
Yeah.
First of all, Dr. Silverstein, I just want to say thank you. Can you hear me okay, doctor?
Sort of. You can talk louder, be better.
All right. Apologies to my fellow Hyperacusis. First of all, Dr. Silverstein, I just want to say thank you for your continued innovation. I'm curious if the tissue on the eardrum affects the eardrum in such a way that those with fullness have worse fullness as a result of the eardrum being reinforced.
We've done too few cases to determine that, but you know, the business of fullness in the ear, we have really not looked at that very much, because I haven't heard very many patients complaining about fullness in the ear. And I'm not sure how that's related to the hyperacusis.
Right, and I certainly do have standard severe hyperacusis, and my final question would be, I'm one of those who would welcome high frequency hearing loss, and I wonder if you can work with the patient and request more tissue, and what is the limiting factor in how much tissue, the sensitivity to hearing loss? Can you just say, hey, doctor, load me up?
Right. So the way we do research is that we develop a procedure and we do a number of patients for a period of time. And then we stop doing that procedure and evaluate the results. So we've gone through 3 stages now. The one where we've just done the round window, then we've done the round window and the oval window. And now we're doing the round window, oval window, and putting extra tissue on top of that. And so we've only done 5 cases, and I've been very impressed with the results. And my impression is that the more tissue you put in, the better result you're going to get. Now, hopefully, what we have now will be enough tissue to cure the hyperacusis or improve the hyperacusis without causing hearing loss, and get a good result, and that we won't have to put in any more tissue. But if we do, we'll try. I mean, that's what research is. You develop a procedure, and then you do it, and then you evaluate the result and go from there.
Thank you.
Joe Sipos has a question.
Yeah, thank you so much. Hopefully you can hear me, Dr. Silverstein, and everyone in the room there. But yeah, just want to express my gratitude for being a pioneer and hyperacusis. And I guess my questions were, if you are nearing retirement, are you planning on publishing some more papers and kind of research studies so that other doctors and ENTs will begin to perform, what you described as a very almost like routine procedure and simple procedure? How do we make sure that like the word about this procedure gets out, and folks in different corners of the country can go to their local otolaryngologist and perhaps get this procedure done?
Well, we've written 4 papers, and we're getting ready. We're working on the 5th paper now, talking about the enhanced reinforcement. I'm working on that paper right now. So it's in the literature, and I've been doing this now for 10 years. So the research has been going on for since 2014. And I think there's, I don't know why more doctors are not doing it, because it's a simple procedure. I can tell you that ENT doctors don't see patients with hyperacusis very much. It's mostly the audiologist. I was in practice 40 years before I saw my first case. So I don't think it's common that ear surgeons get to see these patients. And also, when they go see an audiologist, the audiologist likes to treat the patient with sound therapy, with TRT, and things like that. And so there may be a political problem with having the patient referred for surgery when they can treat the patients with sound therapy or some other therapy.
There's another question. There are reports of people having a bad outcome from the surgery. How high is that risk to be worse after the surgery?
There are some patients where the surgery does not work. And in those patients, the hyperacusis is not caused by hypermobility of the sound mechanism. And it's a more central problem, and it can't be helped by surgery. And those patients, you just don't know which patients they're going to be. But if the patient has a lot of psychological problems before the surgery and other problems, it's probably best not to do the surgery on them. So we try to pick patients that are not complicated and have many different problems along with the hyperacusis. But we have not had any patients, we have not reversed any of the patients, taken any tissue out on any patient. So the bottom line is that if the surgery doesn't work, it doesn't work. And it usually does not cause any worse symptoms. Some patients have had complained of more tinnitus in their ear after the surgery.
We can't hear you anymore.
Okay. It's very gratifying to me. I don't know where I was cut off, but it's been very gratifying as a surgeon to be able to do a procedure, a simple procedure like this on the ear, and get so many fantastic results and so many happy patients. And you just can't please everybody and make everybody well. But I've certainly enjoyed doing the procedure and enjoyed seeing the patients get better. And I think we're getting ready to write another paper for a psychological journal, for a psychiatric journal, because I think it's one of the few operations that you can do and help a patient's mental ability and help their anxiety and depression. Because these patients, many of them are confined to their house. They don't want to talk to people. They want to stay in a room. And after you give them relief, their life changes back to normal, and they can go out in public and do whatever they want to do. So if the surgery didn't work and it didn't get good results from it, we wouldn't be doing it.
Another question is the surgery covered by insurance?
Yes. So the way we bill the surgery, most insurance will pay for the surgery. If you're from Canada, you're going to have to pay cash.
So what happens with people that have the surgery and it gets worse instead of better? How is that treated?
We haven't really treated many patients that have gotten worse.
Okay, so I live in New Jersey. If I take my husband to Florida for you to examine him and he's a candidate, can he do the surgery?
If they're coming from New Jersey to see you for an examination,
Right.
would you be able to do this? Would they be able to have the surgery? if
Okay.
they're coming-
So what happens is that the way we're doing it now is we do a telemedicine interview with the patient. And then we have you send your hearing test and your LDL and a CT scan of the temporal bones to us. And then Dr. Nyack, who I work with, will call you and talk to you. He's doing the surgery now, and I'm observing and supporting in the OR while the surgery is being done. That's the way it's going right now. We have patients coming here from all over, from out of the country, and from all over the United States. They stay here about a week. They usually come on a Wednesday. The surgery's on a Friday. And they stay here for a week, and then we take the packing out of the ear, and they can fly back home.
Another question. Don't most patients have some psychological issues because of the hyperacusis? Wouldn't it be best to not perform the surgery on them?
Well, I haven't found that out. It all depends on how much psychological problem the patient has, and also what other things they have going on besides the hyperacusis. But like I said, that if the surgery works, many times the psychological problem is resolved.
Okay, the next question is, if you have nerve damage to your ear, will this surgery help?
Yes, we've had patients that have had sensory neural hearing loss and that we've operated on, and that we've helped.
Hello.
Go ahead.
So I also have myoclonus in both of my ears. Is there, does this surgery, you were talking about hypermobility of the stapes. Can you speak as to whether this would help with the myoclonus at all, or just having it actually mean that you can't have the round?
I'm not sure about myoclonus.
Okay.
That's why I was saying that we try to pick the patients that have pretty much hyperacusis and related emotional problems related to that.
Okay. Thank you.
The one question that you haven't asked me is how many cases have we done? We've done 79 cases. Friday we're doing the 80th case, and that's patients, and the number of years is about over 100.
How frequent was one of the questions, are cases?
We do them on Friday morning.
Is it?
Usually
Once a month?
usually a couple of months.
Okay.
Yeah.
That was what-
And it usually takes several months to get scheduled for it.
There's a few questions about, is this surgery available in Europe?
The patients are coming from Europe, and I'm not sure about that.
ask a question?
Go ahead.
So years ago, I noticed when I heard very loud sounds, there was kind of a vibration which I could hear, and it seemed to me to be behind my eardrum. Can it be possible that that is the hypermobile mobile stapes that were vibrating?
Christina, could you repeat what he said?
So. Can you repeat that, please?
Should I repeat?
Yes, just a little bit louder, please.
So I noticed years ago when I heard loud sounds, sometimes a noise and a vibration which seemed to be behind my eardrum. Is it possible that the hypermobile stapes were the cause of this problem?
I can't hear that exactly. So
So,
I can write it to the chat.
okay, thank you. They're gonna message it
okay.
and then I'll.
Anything else?
Any other questions?
Hello, I
Hello?
live in San Diego, and I'd like to know if there's anyone in San Diego
Yes.
or Los Angeles.
Yeah, Dr. Ronan Nazarian in Los Angeles.
Rona Nazarian.
Ronan
Thank you.
Nazarian is his name.
He's
he-
there, him as well as Dr. Young, like you mentioned in Las Vegas.
Yes, Dr.
They're all-
Alan Young in Las Vegas, I know, are doing it.
People can find our website, they're our fellows, it's on
Right.
the fellow listing.
Yeah, they can go on our fellow listing on our website, the Ear Research Foundation.
Hello?
So I got the question that we couldn't hear earlier.
Okay, say it loud.
I noticed a noise and vibration that seemed to be behind my eardrum. When I hear very loud sounds, is it possible that loose stapes are what's vibrating?
Yes,
So do you, another question is, do you consult with other ENTs on hyperacusis patients?
I would, sure.
Any other questions?
Can I just
Hello?
confirm?
Go ahead.
Can I ask a question?
Go ahead.
Hi, hello, doctor. Basically, my wife has hyperacusis. She got it basically due to the earwax removal, which was done through the syringing method. And post that, she took the CBT, and her therapist asked her to remove the noise cancellation. Since then, she is not able to tolerate any of the sound. Will she be a candidate for this surgery? And if in case you're doing or these surgeries are supported outside US, or it's only right now available in US,
Okay, go ahead.
because I'm based out of Dubai at the moment.
After earwax removal,
Right.
and wants to know if she would be a candidate and if this surgery is supported only in the US or if you know of other countries that support it.
I'm not sure about the other countries. We've written, like I said, four publications on it. So it's in the literature of how to do the surgery and the results. I think the best thing is to have a telemedicine consult with us. If you have some questions about whether surgery is indicated. And we would tell you about the different tests that you should get and send us the results and whatnot, and we could evaluate it.
Looks like John Wallace has another question.
Yeah, hi. I was just curious, is the stapes hypermobility, do you know or hypothesize, is that a structural issue, just like a loose bone, or is it an innervation from somewhere more complex that causes that hypermobility?
I think it's a loose bone. From the video I showed you, it seemed like the stapes is just very loose in the window, as if the tendon that's holding it there is not very functional. And I would say it's about half the patients have the hypermobility of the stapes. And some of them have very mobile and some moderately mobile and some are normal. But the results of the surgery seem the same, depending, they don't have to have hypermobility of the stapes to have a good result.
Got it. Thank you.
There are a lot of questions, but I will email the answer. It's how to make an appointment.
Right,
I will provide all that information and email it to everyone who is registered.
right.
We will have a recording of this and it'll be out in about a week and I'll email that as well.
Okay, that's great.
I think that's it.
Okay, well, sorry for the delay and the technical problems at the beginning, but we got it going. Thanks.